The theory behind high-frequency ventilation can be explained as follows. The lung is a very stable structure during inspiration and expiration. Here are the images taken from a rat lung using in vivo video microscopy, and you see that during inspiration and expiration of a ventilated lung, the alveoli remain very stable with very little change in their size throughout the cycle. And we have learned with time that the lung doesn't want to be overstretched and doesn't want also to be collapsed during expiration. When the lung is injured, it becomes a very unstable structure. And throughout the years, we have learned that the ventilation will be aimed to keeping the lung as stable as possible. How have we done that with conventional ventilation and APRV? Is by establishing limits to our ventilation. We don't want to overstretch the lung, having plateau pressures that are higher than 30 liters of water. We don't want to go below the requirement pressure to prevent the collapse of the alveoli during the expiratory phase. And as we see here, we try to then obtain what the best PEEP, the positive end expiratory pressure, to prevent the lung collapse during expiration. And we limit ourselves, our titling, to the plateau pressure of about 30 centimeters to prevent overstretching of the lung. So the idea is that if you go below or beyond these limits, that you go to areas of injury where you can, by ventilating the lung, going over these areas, you can generate even further injury to the lung, what we recognize now as ventilator-induced lung injury. The theory behind oscillation is that we could probably remain between these two set limits with much smaller tidal volumes, almost like a wiggle of the lung, and prevent the pressures that could overstretch or under-recruit the lung and remain in a very safe area for the lung as it is. We can see here the alveoli, again, of a rat model, where you can see that with a mean airway pressure of 25 and a PEEP of 15, it is not enough to keep this lung recruited. This is a lung that during the expiratory phase, due to its injury, is see alveolar sacs collapsing and expanding during the inspiratory and expiratory cycles. This is also a rat lung during APRV, and you can see even though the P low is a T low of about 0.4, 0.5 seconds, there's a collapse of the alveolar structures during the expiratory phase, during the volume release, probably because we are going below the pressure that keeps the lung in the expiratory phase. Now compare this to this video of high-frequency oscillatory ventilation, where you see the alveolar structures much more stable, with essentially quivering, with no can collapse or expansion during the expiratory or inspiratory phases of the cycle. This appears to be more consistent with what we normally see during the normal functioning of the lung. These patients traditionally are managed in a stepped sequence, where we start with volume ventilation with low tidal volumes, higher PEEP, based on the recommendations of the ARMA trial of the ES network from the year 2000. If that would fail, most people move to pressure control ventilation with higher PEEP and inverse IE ratios. Some people move to non-conventional ventilation like APRV or high-frequency oscillatory ventilation. And in the centers that are trained and prepared to do so, they may even use extracorporeal membrane oxygenation to support this patient in view of the complete respiratory failure. When do we consider moving to high-frequency oscillatory ventilation? We have had, fortunately, very good experience with this, and we move probably a little earlier than most people do. The way we move is if the patient's doing well, like most of the patients will, with the ARDS network protocol, then we stay there. But if we see that the FiO2 requirements are higher than 60% or 0.6, we see that the plateau pressures are higher than 30 in order to keep adequate ventilation. If we see that we have a mean airway pressure of higher than 20 or a PEEP higher than 15, oxygenation index higher than 10 as well, then we move to high-frequency oscillatory ventilation. How do we start high-frequency oscillatory ventilation? The initial our ventilator consists of an FiO of 1 with an amplitude of 60 to 90 centimeters of water to have our wiggling factor, to shake the chest and the lung. We start with a biof of 30 liters per minute that may be increased depending on how much you need to maintain your mean airway pressure. We start with a frequency of 5 and with a night time of 33%. With these, as we change the patient to the oscillator, we do a recruitment maneuver of 40 centimeters for 40 seconds. And after we have done this recruitment period, we come back down to a 30 centimeter mean airway pressure as we start the oscillation. We want to see at this point in time that the saturations of the patients have increased. Normally, we would have patients with very abnormal saturations in the low 80s or mid 70s or even worse. And our recruitment maneuver would be seeing an improvement in oxygenation as we do the maneuver. We should see saturations that quickly go to the mid 90s or high 90s as we recruit the lung. After we have held that for a period of 40 seconds, then we go down to mean airway pressure of 30 and we start the oscillation. If within the next 20 minutes we don't see a significant increase in the oxygenation of this patient, which is clinically seen as a capability to decrease the FiO2 to 0.6, then we perform a second recruitment maneuver of 40 centimeters for 40 seconds. But instead of coming back down to a pressure of 30, we come back down to a pressure of 35, and you see in the diagram. And after 20 minutes, if we don't see a significant improvement on oxygenation as well, then we may proceed to a third recruitment maneuver, which usually is between a pressure of 45 to 50 for 40 seconds. But instead of coming back down to a pressure of 35, we stop at 40 and leave that there because that's the recruitment pressure that we require for it. We have seen in most of our patients, we use pressure between 35. We have seen that with H1 and 1, we have had to use even higher pressure for these patients in the range of 40 to 45 in order to open the lung and have adequate oxygenation. It's a significant increase in severity of these patients compared to our usual patient that requires this modality of ventilation. Now, this is based on the TOOLS trial. This was published by the group led by Neil Ferguson in critical care medicine. How do we support these patients? Well, these patients have to be deeply sedated. They cannot breathe on their own or have any respiratory drive, because if they breathe on their own, they will start generating negative pressure in the airway. In some cases, at least for the first day or two, they may require, as they improve, neuromuscular blocks that can the breathing at this point in time, obviously with adequate sedation. The suctioning is also very important. I mean, we try to suction them as little as possible, at least during the first 24 to 48 hours, to prevent the generation of negative pressure to require a recruitment. If you do it, we do it, but we try to limit as much as possible the suctioning of these patients. And then, at least from the reports from the groups in Canada, from Manitoba, they've seen that these patients have well with very limited intravenous fluids. We don't want that the perfusion happens adequately, that the kidneys are perfused, that our organs are perfused, but we're perfusing these patients over hydrating these patients has been seen with a worsening oxygenation, possibly because of the appearance of edema, lung again from too much excessive fluid. This has been essentially the recommendation that we have had for the management. Now, once these patients are able to be mean to certain parameters, we can transition these patients from high-frequency oscillation to conventional ventilation. How do we do that? Well, first of all, in order to have some range, some safety, moving these patients to lower parameters, we want to make sure that we have some room with the oxygenation. Consider that the recruitment maneuvers were effective when we're able to FiO2 to 0.6. We start weaning the pressure once we have kept an adequate oxygenation with an FiO2 of 0.4. So we wean first the FiO2 to 0.4. Once we have reached 0.4, very slowly we start decreasing the pressure. The idea of this is that the pressure changes have to be done very carefully. You don't want to move too quickly and then have to go back and re-recruit the lung. You want to assure that in every step of the way you are moving the patient in the right direction without precipitating, a closing of the alveoli. So once you reach an FiO2 of 0.4, we decrease in 2 centimeters the pressure from whatever we were. Let's say we were at 34, then we'll go to 32. Between 4 and 6 hours later, we may attempt going to 32 as long as the patient continues to have adequate oxygenation. Once we have reached with our pressures a level of 20 to 22 centimeters of water, then we transition to a more conventional mode of ventilation. We go to pressure control ventilation with an FiO2 of 0.4, with an inspiratory pressure of 30 and a PEEP of 15, having a driving pressure then of 15 as well, and a 1-to-1 I/E ratio, and a rate of 20. That would be our first transition. These patients are transitioned from the oscillator to conventional ventilation with these settings. We observe them for the next 20 minutes, 30 minutes to make sure that the saturations and that the oxygenation and CO2 removal all stay within the acceptable limits. If we see they will have to be returned back to high-frequency oscillatory ventilation.